Diabetes insipidus, it is an uncommon disorder. It is not so common. It is characterized by excessive and persistent excretion of dilute urine and by excessive thirst. Dilute urine in this disease is because of inability of the renal tubules to reabsorb water, because of which water will flow into the urine and will make it dilute. Thirst is because of increased plasma osmolarity. Since there is decreased reabsorption of water from the renal tubules, plasma osmolarity will rise, and increased plasma osmolarity or hypertonic or concentrated plasma will stimulate the thirst center. Diabetes insipidus, it is of three types: cranial, nephrogenic and gestational. Other names of cranial diabetes insipidus are central diabetes insipidus, pituitary or neurohypophyseal or neurogenic diabetes insipidus. In cranial and gestational diabetes insipidus, antidiuretic hormone is decreased. But in nephrogenic diabetes insipidus, ADH is normal or can be abnormally high. It is because of it is like ADH resistance. Cranial diabetes insipidus, in which there is deficient production of antidiuretic hormone. Its causes are structural hypothalamic lesions. The major hypothalamic lesions that cause diabetes insipidus are listed here. Tumors like adenoma, craniopharyngioma and meningioma. Adenoma, it is a benign tumor of the epithelial cells. Craniopharyngioma, it is also benign tumor of the pituitary gland embryonic tissue. Meningioma, it is in 90% of the cases benign. It is a slowly growing tumor arising from the meninges covering the brain and spinal cord. Likewise, head injury or trauma can cause central diabetes insipidus. Surgery or radiotherapy in and around the sella turcica region called sellar and parasellar surgery or radiotherapy can also cause cranial diabetes insipidus. In genetic defects, the main is arginine vasopressin gene mutation. In this gene mutation is inherited as autosomal dominant mode. This gene mutation is not present from the birth but develops later after many months to several years. Once this mutation is established, arginine vasopressin becomes deficient permanently. But for some unknown reasons, diabetes insipidus caused due to this gene mutation improves spontaneously in the late middle age. Another genetic defect is mutation in the WFS1 gene. This gene mutation is responsible for Wolfram syndrome. Its components are DI for diabetes insipidus, DM for diabetes mellitus, OA for optic atrophy, that is degeneration of the optic nerve, and D for deafness. In contrast to arginine vasopressin gene mutation, Wolfram syndrome is inherited as autosomal recessive. In about 50% of the adult patients, cranial diabetes insipidus is idiopathic. In nephrogenic diabetes insipidus, antidiuretic hormone, it is not deficient, rather it is abnormally high. But the problem here is the decreased responsiveness of the renal tubules to antidiuretic hormone because of the problem or disease in the kidneys. The causes of nephrogenic diabetes insipidus are classified as genetic disorders, metabolic abnormalities, drug therapy, poisoning and chronic kidney disease. First, genetic. In genetic disorders, there are mainly three disorders: cystinosis, B2 receptor mutation and aquaporin 2 mutation. Cystinosis, it is a autosomal recessive genetic disorder in which there is accumulation of cysteine, that is amino acid cysteine, in the lysosomes, and it forms crystal inside the cell and damages the cell. Especially kidneys and eyes, they are affected in the genetic disorder cystinosis. B2 receptor is a receptor present in the epithelial cells of the kidney on which antidiuretic hormone acts. If there is mutation in the B2 receptor, then ADH cannot bind on it and it causes diabetes insipidus. This B2 receptor mutation is inherited as X-linked recessive disease and its presentation is in the young boys. Next is aquaporin 2 mutation. Aquaporin 2, it forms water channels on the luminal membrane, due to which water can be easily reabsorbed into the cell and then into the renal interstitial fluid. If there is mutation in the aquaporin 2, then water channels cannot function. Next is metabolic abnormality. Hypokalemia and hypercalcemia and hypercalciuria can cause diabetes insipidus. Drugs like lithium and demeclocycline. Lithium, can cause diabetes insipidus. Lithium, it is a drug which is given in the bipolar disorder, that is mania and depression. Next is demeclocycline. Demeclocycline, it is a tetracycline antibiotic which is prescribed in syndrome of inappropriate ADH secretion to reduce ADH. Next is poisoning by the heavy metals like lead and mercury can also cause nephrogenic diabetes insipidus. Chronic kidney diseases like polycystic kidney disease, sickle cell anemia, and infiltrative disorders like amyloidosis can also cause nephrogenic diabetes insipidus. Let's know about other two terms, gestational diabetes insipidus and primary polydipsia. In gestational diabetes insipidus, similar to cranial diabetes insipidus, there is decreased ADH, but the mechanism or the reason for decreased ADH is different. There is no problem or lesion in hypothalamus or posterior pituitary, but placenta in second or third trimester secretes an enzyme called N-terminal aminopeptidase. This enzyme causes a degradation of ADH 3 to 4-fold than the normal. So it causes decreased ADH and reabsorption of water cannot take place through renal tubules. Primary polydipsia, it is not diabetes insipidus. It is a different term, it is a different entity, but it is an important differential diagnosis of diabetes insipidus. In primary polydipsia, there is excessive intake of the fluids by the patient. It is of three types, dipsogenic, psychogenic, and iatrogenic. In dipsogenic primary polydipsia, there is abnormal thirst. Thirst is inappropriate, because of which patient takes excessive fluids. Unlike in dipsogenic, in psychogenic primary polydipsia, there is no inappropriate or abnormal thirst. But here in psychogenic primary polydipsia, because of psychosis or obsessive compulsive disorder, patient takes excessive fluids. In iatrogenic primary polydipsia is caused because of recommendation by doctor to take enough fluids or more fluids for health benefit. The pathogenesis of diabetes insipidus and primary polydipsia is just reverse. In diabetes insipidus, first there is either decrease in ADH or unresponsiveness to ADH, because of which reabsorption of water cannot take place. It causes polyuria and polydipsia because if there is no reabsorption of water, then it will cause increased plasma osmolarity, that is, it will cause concentrated plasma, and because reabsorption of water cannot take place and what is lost through the urine osmolarity will decrease, that is, urine will become dilute. But primary polydipsia, the pathogenesis is just reverse. There is either abnormal thirst, as in dipsogenic primary polydipsia, or there is abnormality in the cognition, like that of psychogenic primary polydipsia, because of which there is excessive intake of the fluids. Because of excessive intake of the fluids, plasma will be diluted, that is, plasma osmolarity will decrease, and urine osmolarity will also decrease because of dilute urine. Because of decreased plasma osmolarity, antidiuretic hormone will decrease, because we know that increased plasma osmolarity increases ADH, decreased plasma osmolarity decreases ADH. So diabetes insipidus, decreased ADH is causing the problem, and in primary polydipsia the end result is decreased ADH.